Welcome to this deep dive, where we sift through the complex to bring you the core knowledge you need. Today, we're untangling metabolic acidosis. It sounds pretty formidable, but we'll break it down.
Exactly. And it's important, to get the terms right first. At its core, metabolic acidosis is a process. It's where the body's overall pH tends to decrease.
Okay, the process.
Right. Now, if the actual blood pH drops below the normal range, that specific state is called acidemia.
So acidosis is the trend, acidemia is the low blood pH snapshot. Got it.
Precisely. Think of it that way.
Okay, so what's the fundamental shift happening chemically in the body to cause this trend?
Well, the central issue really is a drop in plasma bicarbonate. HCO3. Bicarbonate is just a critical buffer in the bloodstream, keeping pH stable.
Right, the buffer.
Yeah. So generally for dogs, you want levels above, say, 18 MQL. For cats, it's a bit lower, maybe above 16 MQL. If those numbers dip, and we also see a fall in base excess, that's another marker of the overall acid-base balance.
Sure.
And importantly, a compensatory decrease in the carbon dioxide tension, the PCO2, in the blood. Well, then metabolic acidosis is really the picture we're looking at.
So lower bicarbonate, lower base excess, and the body trying to compensate by lowering CO2.
Yeah.
Makes sense. Now, we've learned there are sort of two main routes this can happen. Can you walk us through those?
Certainly. One path involves the actual loss of bicarbonate from the body, just gone. When this happens, it often leads to what's called hyperchloremic acidosis.
Hyperchloremic or chloride.
Exactly. Because as that negatively charged bicarbonate is lost, the body tends to hang on to more negatively charged chloride to try and keep the electrical balance. It's a trade-off.
Okay, that makes sense. Lose one negative, keep another. What's the second path?
The other main way is a gain in acids other than chloride, different acids building up. This results in what we call high anion gap acidosis.
High anion gap. Okay.
So one's about losing a base bicarbonate, the other is about gaining some other kind of acid. Two distinct mechanisms.
High anion gap. Hyperchloremic. Yeah, you can already see the different diagnostic trails. So this deep dive is really about understanding these key signals, uncovering the potential triggers, the causes, and grasping the critical things you need to keep in mind. Our aim really is to distill all this detailed medical info so you can understand the core concepts without feeling like you're, drowning in jargon.
That's the plan.
Let's start by digging into the why then, the underlying pathophysiology.
Right. Let's tackle hyperchloremic acidosis first. As we just said, this primarily comes from a loss of bicarbonate. Think of bicarbonate as like your body's natural antacid if you're losing it. The body tries to keep things electrically neutral. And one way it does that is by retaining chloride ions. Hence, the hyperchloremic part, increased chloride concentration.
That makes intuitive sense. Like one goes down, the other tries to step in to fill the gap electrically. Now, what about the other type? What ignites high anion gap acidosis? What's causing that buildup of other acids?
Okay, high anion gap acidosis. This happens when acids other than chloride accumulate. Our sources point to a couple of key scenarios here. One is the buildup of what we call strong anion.
A strong anion.
Yeah, these are acids that basically readily dump a lot of hydrogen ions into the system, really pushing down the pH. Prime examples.
Right.
Well, ethylene glycol toxicity is a classic one. Antifreeze. Highly dangerous.
Right, antifreeze. Heard of that one.
We also see it with excessive lactate production, lactic acid. That happens when the body's tissues aren't getting enough oxygen. Think prolonged anaerobic metabolism, like in severe shock or maybe even extreme prolonged exertion.
Okay, lack of oxygen.
And finally, kidney failure is a big one here too. If the kidneys aren't working properly, they can't filter out these strong anions effectively, so they just build up.
So toxins, oxygen deprivation, and kidney dysfunction. Key players for those strong acids.
Definitely.
What's the other way you mentioned for getting a high anion gap? You said weak acids.
That's right. The other route involves the accumulation of certain weak acids. And the sources specifically highlight hyperphosphatemia, high phosphate levels in the blood.
Okay.
Yeah, phosphate itself acts as a weak acid. So when its levels climb, and this can happen for various reasons, maybe impaired kidney excretion and renal failure, issues with the parathyroid gland, maybe cells breaking down rapidly like in tumor lysis syndrome or major trauma.
Yeah, lots of possibilities.
Even bone tumors or getting way too much vitamin D can raise phosphate. When this extra phosphate builds up, it contributes to the acidosis. And what's really interesting is the direct link they found. At a normal body pH, around 7.4, for every 1 milligdl increase in phosphate, but carbonate can actually decrease, and the anion gap can increase by about 0.58 LEQL.
That's a surprisingly direct connection. So things we might not immediately link to acid-base balance, like, bone issues or vitamin levels, can actually play a role. That's
It
fascinating.
really is. Shows how interconnected everything is.
Now, the sources also mentioned something about this sometimes being a compensatory mechanism.
Hmm.
For respiratory alkalosis, how does that work?
Oh, right. Yes. So if the body initially has respiratory alkalosis, meaning it's breathing off too much CO2, causing the pH to go up,
Okay, high pH?
the kidneys can try to correct this. They can step in and start retaining more acid and excreting more bicarbonate, trying to pull that pH back down. This compensatory action by the kidneys can sometimes look like metabolic acidosis on blood work because you'll see lower bicarbonate. But it's really the body trying to fix the initial respiratory problem.
Ah, okay. So the body's response to one imbalance can look like another imbalance. It really highlights how these systems are constantly talking to each other.
Constantly adjusting, trying to maintain that equilibrium.
It truly is all connected.
Yeah.
Okay, let's shift focus back to the hyperchloremic type for a second. We talked about bicarbonate loss leading to chloride retention. What are some specific situations where we might see that bicarbonate actually being lost?
Well, as we mentioned, chloride retention often follows bicarbonate loss, maybe from kidney issues like renal failure or specific problems called renal tubular acidosis. That reciprocal relationship is key.
Right, the seesaw.
But hyperchloremic acidosis can also pop up when there is an excessive loss of sodium relative to chloride. Think about conditions causing severe diarrhea, where you lose a lot of bicarbonate-rich fluid,
Oh, diarrhea makes sense.
or Addison's disease, hypoadrenocorticism, which affects the adrenal glands and electrolyte balance. And interestingly, it can even happen just from giving certain IV fluids.
Fluids, how so?
If you administer fluids that have a higher chloride concentration compared to sodium than what's normal in the body's extracellular fluid, like standard 0.9% saline, or fluids with added potassium chloride, that relative excess of chloride can nudge the balance towards hyperchloremic acidosis. Though it's worth noting, the resulting acidemia from fluids is usually less severe than from, say, severe diarrhea.
Okay, so even our treatments can sometimes contribute, albeit usually mildly. Good to know. So we've mapped out the two main pathways, losing bicarb or gaining acid. Now, what happens when metabolic acidosis actually takes hold in the body? Which systems really feel the effects?
Several key systems respond, definitely. Let's start with the cardiovascular system, the heart and blood vessels. A drop in pH has a kind of two-stage effect, and it really depends on how low the pH gets.
Sure.
In mild acidemia, where the pH is still above, say, 7.2, the body actually ramps up its sympathetic nervous system, releases more adrenaline, noradrenaline. This can initially lead to an increased heart rate and stronger heart contractions, more cardiac output, kind of a stress response.
So initially, it tries to boost things.
Right, but, and this is crucial, in more severe acidemia, especially if it develops quickly and the pH drops below about 7.1, the direct effect on the heart muscle itself is negative. It can weaken the heart's ability to contract, decreasing cardiac output.
Oh, so it flips from a boost to a drag?
Exactly. And worse, this severe acidemia significantly increases the risk of dangerous heart rhythm problems, arrhythmias, ventricular arrhythmias, even ventricular fibrillation. It makes the heart electrically unstable.
Wow. So potentially life-threatening situation if it gets severe.
Absolutely.
Okay, heart effects are clear.
Right.
What about the respiratory system? We touched on compensation earlier, the breathing changes.
Yes, exactly. When the concentration of hydrogen ions in the blood increases, that's the core of acidosis, right?
Right.
It stimulates specialized sensors called chemoreceptors. There are some in the periphery, like in the carotid arteries, and also centrally in the brain. These sensors monitor oxygen, CO2, and importantly, pH. In response to those increased hydrogen ions, the signal goes out to breathe faster and deeper, increase ventilation.
To blow off CO2.
Precisely. Carbon dioxide acts like an acid in the blood, so by increasing ventilation, the body expels more CO2. Lowering the PCO2 in the blood helps to counteract the low bicarbonate and nudge the pH back up towards normal. It's a key compensatory mechanism.
And is this response predictable?
Reasonably so in dogs. The general rule of thumb is for every 1 EBQL decrease in bicarbonate, you typically expect to see about a 0.7 mmHg drop in PCO2 as compensation kicks in.
Okay.
Unfortunately, our sources consistently point out that cats seem to have a much more limited ability to compensate effectively through respiration compared to dogs.
Huh. So dogs have a slightly better built-in mechanism to try and breathe their way towards balance, at least somewhat. Interesting.
It seems that way, yeah.
And finally, what about the kidneys? They're kind of the long-term regulators of acid base, aren't they?
They absolutely are. The kidneys are crucial for long-term balance. They respond to metabolic acidosis by increasing what are called net acid excretion, basically getting rid of more acid.
How would they do that?
Primarily by increasing the excretion of ammonium NH4 plus GOES. That's a major way the kidneys package up and eliminate excess hydrogen ions. They also tend to excrete more chloride along with it. However, similar to the respiratory compensation issue, this kidney-based mechanism is also generally considered less effective or slower to respond in cats compared to dogs.
So cats might be a bit more challenged in compensating overall, both breathing-wise and kidney-wise.
That seems to be the consensus, yes.
Okay, we've explored the causes and the body's immediate responses. Now let's think about detection. What kind of clues might we see in a patient that would make us think, maybe metabolic acidosis is playing a role here? Are there certain breeds or ages more susceptible? Or specific things in their history or on exam?
Well, first off, the information indicates that metabolic acidosis isn't really picky. It can affect any breed, age, or sex of dog and cat. No strong signalment predisposition there.
Okay, so it's widespread.
Right. However, the animal's history can provide really significant clues. You definitely want to be thinking about it if there are chronic underlying conditions known to predispose. Things like chronic kidney failure, that's a big one, diabetes mellitus, especially leading to ketoacidosis, and hypoadrenocorticism, Addison's disease.
Okay, chronic diseases.
Yes. But acute situations are also really important. Severe circulatory shock, maybe from trauma or blood loss, and toxin exposure is critical to ask about. Again, ethylene glycol is high on the list, but also things like salicylates aspirin-related compounds or paraldehyde.
Right, toxins.
Even seemingly common problems like severe ongoing diarrhea can cause significant bicarbonate loss and lead to metabolic acidosis.
Makes sense, losing fluids and bicarb.
And lastly, don't forget medications. Certain drugs, particularly a class called carbonic anhydrase inhibitors, can interfere with bicarbonate handling and cause acidosis.
So a really broad range of historical factors could raise your suspicion.
Definitely need to cast a wide net when taking the history.
Okay, that's the history. What about what we might actually observe during a physical examination? Are there telltale signs?
Well, often the physical exam findings are, more related to the underlying cause of the acidosis rather than the acidosis itself.
Oh.
However, in animals with significant metabolic acidosis, you might see more general, nonspecific signs. Things like depression, lethargy, maybe even progressing to stupor in severe cases. Generalized muscle weakness can occur, especially if it's severe or associated with electrolyte shifts like potassium changes.
Muscle weakness, okay.
Because the body tries to compensate by breathing faster, you might observe tachypnea, just rapid breathing.
A respiratory compensation we talked about.
Exactly. Now, it's interesting. In human medicine, you often hear about a specific breathing pattern called Kussmaul's respiration. Very deep, labored breathing. But our sources specifically emphasize this is not typically seen in dogs and cats with metabolic acidosis, so don't expect that classic human sign.
Okay, good distinction. No Kussmaul's breathing typically in our animal patients. That's useful to know.
Yeah. And you might also see signs like vomiting or diarrhea, which, as we've kind of discussed, can be both a cause and sometimes a consequence or related sign.
Right, can go both ways.
Okay.
Okay, so if we suspect metabolic acidosis based on this history and maybe some non-specific physical exam signs like tachypnea or lethargy, how do we definitively diagnose it? How do we pin it down?
Well, here's a critical point. Sometimes low bicarbonate and high chloride levels can actually be seen as a compensatory response in animals that have chronic respiratory alkalosis, the body trying to fix a different problem.
Ah, the compensation issue again.
Exactly, and that's why blood gas analysis is absolutely essential. You really can't reliably diagnose or differentiate metabolic acidosis without it. Blood gas gives you the actual pH, the PCO2, and the bicarbonate level directly measured. It paints the complete acid-based picture.
So blood gas is really the cornerstone of diagnosis here. No shortcuts.
No shortcuts if you want an accurate picture, definitely.
Okay. Beyond the blood gas itself, what other laboratory findings are important to consider? Maybe things that affect the results or give more clues.
Yeah, several factors related to lab analysis are really important to keep in mind. First, certain drugs can interfere. For example, potassium bromide, which is sometimes used for seizure control. Some lab analyzers can mistakenly read bromide ions as chloride ions.
Oh, really?
Yeah, so that can falsely elevate the measured chloride and, as a result, falsely lower the calculated anion gap. Something to be aware of if a patient is on bromide.
Good point. What else?
How the blood sample is handled is also critical. Using too much heparin anticoagulant in the syringe, the sources suggest more than maybe 10% of the sample volume can actually dilute the sample and falsely decrease the measured bicarbonate.
Okay, handling matters.
It does. And sample timing. If blood gas samples aren't analyzed promptly, if they sit around at room temperature for too long, say more than 15 minutes or so,
Hmm,
metabolism by the blood cells continues, producing CO2. This increases the PCO2 in the sample and can falsely lower the measured pH. So prompt analysis is key.
right, run it quickly.
And one more big one, albumin levels. Low blood albumin, hypoalbuminemia, can significantly lower the calculated anion gap.
Why is that?
Because albumin is a negatively charged protein, it normally contributes a significant chunk of those unmeasured anions that make up the anion gap. If albumin is low, there's less negative charge, so the calculated gap shrinks. For instance, they estimate in dogs, at a normal pH, a 1 GDL decrease in albumin can lower the anion gap by roughly 4.1 MEq a whole. That's quite a bit.
Wow, yeah, so you really need to consider the albumin level when interpreting the anion gap.
Absolutely. You might need to calculate a corrected anion gap based on the albumin level.
Okay, so lots of potential pitfalls just in getting and interpreting the lab results. What about standard blood work, like a CBC or a regular biochemistry panel? Can that help?
It can provide clues, definitely. A low total CO2 level, often labeled TCO2, on a standard biochemistry panel can be suggestive of metabolic acidosis. In a properly handled serum sample, TCO2 generally reflects the bicarbonate concentration pretty closely.
So low TCO2 might point towards it.
It might. But just like we said about isolated low bicarbonate and high chloride, patients with chronic respiratory alkalosis can also have low TCO2 as their kidneys compensate by dumping bicarbonate.
Ah, back to the same problem.
Exactly. So while low TCO2 is a hint, it's not diagnostic on its own. We really circle back to the fact that blood gas analysis giving you pH, PCO2, and bicarbonate is the definitive tool. It lets you see the whole pattern.
Okay, message received loud and clear. Blood gas is the gold standard. Now, we've mentioned the anion gap quite a few times. Can you just break down again how that's calculated and exactly what information it gives us?
Absolutely. The anion gap fundamentally represents the difference between the commonly measured positive ions, flocations, and the commonly measured negative ions, anions, in the blood. Primarily, it's sodium, and sometimes potassium is included, minus chloride and bicarbonate.
Okay, the main players.
Right. So the formulas you'll see are anion gap is equal to sodium concentration, bicarbonate concentration plus chloride concentration. Or, if potassium is included, anion gap equals sodium plus potassium, bicarbonate plus chloride. You need to know which formula your lab uses or which one you're calculating.
And what are the normal ranges?
They vary slightly between labs, but typical normal ranges when potassium is included in the calculation are around 12 to 24 mQl in dogs and maybe 13 to 27 mQl in cats.
Okay, and remember the albumin effect.
Yes, always remember the albumin effect. Low albumin will artificially lower that number.
So what does a normal versus high anion gap tell us in the context of metabolic acidosis?
This is where it gets really useful diagnostically. A normal anion gap in a patient with metabolic acidosis usually points towards that hypochloremic type we discussed. It suggests the main issue is a loss of bicarbonate, and chloride has increased to fill that anion space, keeping the overall gap normal. Think diarrhea, renal tubular acidosis.
Okay, normal gap, hyperchloremic bicarb loss.
Generally, yes. Conversely, a high anion gap typically points towards normochloremic metabolic acidosis. This means the acidosis is being driven by an increase in other unmeasured acidic anions, not chloride. Those strong acids like lactate, ketoacids, uremic acids, toxins like ethylene glycol metabolites, they're filling the gap.
High gap equals normochloremic equals gain of other acids.
Exactly. So the anion gap is a really powerful tool for categorizing the acidosis and narrowing down the potential causes.
And I suppose other findings on the biochem panel can help too.
Oh, absolutely. Finding things like very high blood glucose obviously points towards diabetic ketoacidosis. Elevated kidney values, azotemia, suggest uremic acidosis. High phosphate suggests hyperphosphatemic acidosis, maybe from renal failure or other causes we listed. High lactate confirms lactic acidosis. Potassium can be seen with certain types, especially acute acidosis or kidney failure. Each of these provides important pieces of the diagnostic puzzle, complementing the blood gas and anion gap findings.
So the anion gap plus other lab values, and critically, the blood gas analysis. That whole picture really helps pinpoint the diagnosis and hopefully the underlying reason for the imbalance. Which brings us to treatment. How do we go about correcting this? What's the approach?
Well, the most fundamental principle, the absolute number one priority in treating metabolic acidosis, is to identify and address the underlying cause. The acid-base disturbance is almost always a symptom or a consequence of some other primary problem. Fix the root cause, and the acidosis often resolves or becomes much easier to manage.
Treat the patient, not just the number.
Exactly. And before you even think about giving medications specifically to raise the pH, like bicarbonate, it's critical to restore adequate blood volume and tissue perfusion. Especially in shocky patients, good circulation is key.
Fluids first.
Often, yes. Fluids to restore volume and improve oxygen delivery. Then, for patients with severely low blood pH, the sources generally suggest being aggressive if the pH is 7.1 or lower. You need to rapidly try and determine the specific cause while starting supportive care. And of course, if any medications are suspected of contributing to the acidosis, they should be stopped if possible.
Makes sense. What kind of fluids are best?
For milder cases of metabolic acidosis, assuming the patient's liver function is okay, isotonic buffered electrolyte solutions are often preferred. Things like lactated Ringer solution or plasma-lyte. These contain buffers like lactate or acetate that the body can convert to bicarbonate, helping to counteract the acidosis, unlike, say, 0.9% saline, which can be slightly acidifying, as we discussed.
Okay, buffered fluids for milder cases. Now, what about actually giving sodium bicarbonate to directly raise the pH? When is that appropriate?
Yeah, sodium bicarbonate and HCO3 can be beneficial, but it's definitely not for every case. Its use is quite specific. It's considered potentially helpful in certain types of metabolic acidosis, specifically hyperchloremic acidosis, where bicarb was lost, hyperphosphatemic acidosis, or uremic acidosis associated with kidney failure.
Okay, those specific types. Where is it not recommended?
It's generally not recommended and can even be potentially harmful in lactic acidosis.
Why not for lactic acidosis?
The thinking is that giving bicarbonate might actually worsen intracellular acidosis and potentially increase lactate production in that scenario. The focus for lactic acidosis really needs to be on improving oxygen delivery and circulation to stop the lactate production at its source.
Okay, fix the oxygen problem first.
Right. And the other big one where it's generally contraindicated is diabetic ketoacidosis, DK.
Really? Even if the pH is very low in DKA?
Yes. Our sources are pretty clear on this, citing unfavorable outcomes observed in human studies when bicarbonate was used in DKA. It doesn't seem to improve outcomes and might have downsides. The standard and generally effective treatment for DKA is insulin therapy and aggressive fluid resuscitation. This allows the body to stop producing ketones and allows the kidneys to excrete the existing ketones, which corrects the acidosis naturally.
So for DKA, stick to insulin and fluids, avoid the bicarb. Good to know.
Definitely. So bicarbonate is really reserved for specific situations.
So if we do decide to use it, say for severe hyperchloremic acidosis with a pH below 7.1 or perhaps uremic acidosis, how do we figure out the dose?
There are formulas to estimate the bicarbonate deficit, aiming to bring the patient's bicarbonate level up towards a safer, though not necessarily perfectly normal, level. For dogs, a common formula is dose in MEQ, equal 0.3x body weight, KEG, desired bicarbonate, measured bicarbonate. Often a target desired bicarbonate of maybe 15 or up to 21 mQL is used initially.
Okay. And for GATs?
Similar concept, but the volume of distribution factor might be slightly different. Or a lower target bicarb, like 19, might be used in the calculation. You'd need to check specific references. Crucially, you typically only administer about half of this calculated deficit slowly intravenously over maybe 30, 60 minutes or even longer.
Only half? Why?
To avoid overshooting and causing metabolic alkalosis, and because the body will also generate some bicarbonate naturally as the underlying condition is treated. After giving that initial partial dose, you absolutely must recheck blood gases to see the effect and decide if more is needed.
Okay, slow administration, give half, then recheck. Makes sense. Is there an alternative dosing approach?
Some clinicians prefer a more empirical starting dose, maybe 1 to 2 millieq per kilogram of body weight, given slowly, followed by reassessment with blood gases. Still requires that careful monitoring.
Slow administration seems key. What are the risks if you give it too quickly or too much? What complications can arise?
Yeah, slow administration is vital because there are several potential complications with bicarbonate therapy. One is volume overload, simply due to the sodium and fluid being administered. This is a big concern in patients with heart failure.
Right, the sodium load.
It can cause shifts in electrolytes, potentially leading to hypokalemia, low potassium, and also hypocalcemia, low ionized calcium, which can cause muscle twitches or tetany. It can also increase the affinity of hemoglobin for oxygen, meaning the red blood cells hold on to oxygen more tightly and might not release it as effectively to the tissues. Not ideal.
Counterintuitive effect there.
A bit, yeah. And paradoxically, while it raises blood pH, it can sometimes worsen acidosis within the central nervous system. CO2 generated from the bicarbonate crosses the blood-brain barrier easily, while bicarbonate itself crosses slowly.
Wow, okay. Complex effects.
And of course, there's the risk of overcorrection pushing the pH too high and causing metabolic alkalosis, which has its own set of problems.
So it's clearly a potent treatment with a significant list of potential downsides. Requires very careful use and monitoring.
Absolutely. It's not something to be used lightly.
Are there any situations where sodium bicarbonate is absolutely contraindicated, where you just shouldn't use it at all?
Yes, definitely. It should absolutely be avoided in patients who already have respiratory acidosis,
Why is that?
because bicarbonate reacts with acid to generate carbon dioxide, CO2. If the patient can't breathe off that extra CO2 effectively because of respiratory disease, giving bicarbonate will just worsen the acidosis by increasing PCO2.
Okay, makes sense. No bicarb, but they can't breathe well.
Right. It's also generally contraindicated if the patient is on certain diuretics that act late in the kidney tubules, like spironolactone, or if they're on carbonic anhydrase inhibitors. And interestingly, the sources advise against using it in very acute cardiac arrest, like if the arrest happened less than 10 minutes prior. The concern, again, is potentially impairing oxygen delivery during resuscitation efforts.
Okay, specific drug interactions and that acute arrest scenario.
And finally, while maybe not an absolute contraindication, you have to use it with extreme caution in patients with congestive heart failure because of that significant sodium load we mentioned. It can easily push them into fluid overload.
Right, very important precautions. So let's say we've initiated treatment fluids, maybe bicarbonate if appropriate, addressing the underlying cause. What does the follow-up care look like? How do we monitor these patients?
Close patient monitoring is absolutely essential. You need to regularly reassess their acid-base status with repeated blood gas analyses.
How often?
The frequency really depends on the severity of the initial acidosis, the underlying cause, and how the patient is responding to treatment. It might be every few hours initially in a critical patient, then less frequently as they stabilize. You're watching the pH, bicarbonate, PCO2, and also electrolytes very closely.
And looking out for complications.
Exactly. You need to be vigilant for potential complications of the acidosis itself or the treatment. For example, hyperkalemia, high potassium, can sometimes be seen, especially with acute hyperchloremic acidosis. And as we discussed, particularly in severe acidemia, there's that ongoing risk of myocardial depression, poor heart function, and ventricular arrhythmias. So cardiac monitoring might be needed in severe cases too.
So ongoing assessment of blood gases, electrolytes, and overall clinical status is key to guiding treatment adjustments and catching problems early.
Continuous assessment and adjustment is the name of the game.
Okay, well, this has truly been a comprehensive deep dive into the complexities of metabolic acidosis.
It really has, and I think it underscores just how delicate the body's acid-base balance is and how many things can potentially disrupt it. But the crucial takeaway message, I think, is that identifying and treating the underlying cause is always the cornerstone of successful management.
Absolutely, treat the source. And understanding those fundamental differences between the types hyperchloremic versus high anion gap and how the body tries to compensate, it really provides a much clearer framework for approaching these cases.
Precisely. It helps you interpret the lab data more effectively and guides your diagnostic and therapeutic plan. It also just highlights, again, how interconnected everything is: kidneys, lungs, cardiovascular system, metabolism. An imbalance in one area triggers this cascade of effects elsewhere.
It really makes you appreciate the elegance and complexity of physiology and how many seemingly unrelated factors can subtly influence something as fundamental as the body's pH. Thanks so much for illuminating this really intricate topic for us. It leaves you wondering, doesn't it, considering the diverse causes we discussed. What other, maybe less obvious conditions or factors out there might be having subtle yet significant impacts on acid-base equilibrium that we don't always think about? Something to ponder.